Welcome to the Canadian Liver Foundation's 2022 LIVERight Health Forum, Ask the Experts series. This week-long virtual health forum will present important information on fatty liver disease, how increased alcohol consumption during the pandemic can impact our liver and mental health, as well as what all parents should know about children and liver disease. As our commitment to diversity, equity, and inclusion, we will bring liver and mental health educators from a variety of cultural backgrounds to ensure inclusivity, cultural sensitivity as we deliver our educational programming to a diverse audience. This year, we are offering these sessions in English, French, Chinese, and Punjabi. To kick off this week's session, I have the pleasure of introducing our first speaker, Dr. Mamatha Bhat. Dr. Bhat is a hepatologist and clinician scientist at University Health Network and assistant professor at University of Toronto. She has over 100 publications to her credit and is on the executive committee of the Canadian Donation and Transplant Research Program. Today, Dr. Bhat will speak on the topic, Fatty Liver, Do You Have It? Please join me in welcoming Dr. Mamatha Bhat and our returning host, Dr. Valeria Zaborska.
Fatty liver, do you have it? Hi, Dr. Mamatha Bhat. My name is Dr. Zaborska or Valerie. Thank you for joining us today. I'm going to start with our questions. And the first question to start the session, what is considered fatty liver? How is it diagnosed? And does having fatty infiltration on an ultrasound necessarily correlate to having fatty liver?
Hey, well, thank you so much for the opportunity to speak to the membership of the Canadian Liver Foundation and beyond today. So thank you, Valeria, and to the organizers for this opportunity. It's my pleasure to be here. So with respect to your question, fatty liver disease is a term that we use to describe accumulation of fat within the liver. And this can arise in up to 30% of the population. So we know based on population studies that 25 to 30% of the North American population has some degree of fat within their liver. Now, the question is, what proportion of those ultimately develop significant enough liver disease to result in cirrhosis or full-fledged scarring of the liver? So the liver sees fat accumulation, significant fat accumulation, as an insult. And so you can have inflammation in response to that fat accumulation. And that ultimately triggers accumulation of scar. So really upon seeing this sort of damage, then the liver's mechanisms to try to heal itself are triggered. And so over time, there can be this scarring response in a certain proportion of individuals. And what we know based, again, on population studies is that, say, 100 people have what's called fatty liver disease, then 5 of those over time, over many years, can develop cirrhosis of the liver. So over 20 years and more than that, can develop cirrhosis, which is full-fledged scarring of the liver, which ultimately can result in dysfunction of the liver. So 2 to 3 out of those initial 100 can develop what's called end-stage cirrhosis, decompensated cirrhosis, with all of the complications, and then need to be considered for a liver transplant. So this is really, say, a broad term, fatty liver disease, and certainly it can cause problems in a certain proportion of individuals. Now, the reason it's so important in the Canadian population is because of increasing rates of overweight or obesity, as well as diabetes. So these have been surging in recent years, and that really has brought along with it an increase in fatty liver disease. And right now, it's actually the most common chronic liver disease among Canadians. And so if you think about 25–30% of the Canadian population being affected by fatty liver disease, of those people, a certain proportion of them, so 5% of that population, will then develop cirrhosis over many years.
And then you were mentioning being overweight.
Yes.
Can someone that is not overweight or of a normal BMI still have fatty liver?
Yeah, so fatty liver actually is the culmination of different risk factors. So there are certain genetics or genetic risk factors that can contribute to the development of fatty liver disease. And so we know that there are certain gene mutations or gene changes that increase the risk of fatty liver disease. So there are people who are not overweight who can develop fatty liver disease, and the the inflammation associated fatty liver disease, which is called NASH. So many of you may have heard of that term called non-alcoholic steatohepatitis, which is basically inflammation of the liver in response to the fat. And so that can develop even in individuals who are of normal body mass index.
And then, so going back to sort of a part of the question, for diagnosis, are there specific symptoms, lab tests, imaging that you can do that would point a doctor to make this diagnosis? And how is that different between non-alcoholic fatty liver disease and then non-alcoholic steatohepatitis?
Yeah, so the diagnosis of NASH really is based on, say, exclusion of other issues. So normally when we see elevated liver enzymes in an individual, then we will check for the presence of any viral infections, such as hepatitis C, hepatitis B. We will ask the individual whether they have had any significant alcohol consumption history. And we will also check to see if there's any increased iron storage in the liver. So there's any disease of iron overload or any autoimmune liver disease. So there are various tests that we can do to determine whether any of these conditions are contributing to those elevated liver enzymes. So the reality is that elevated liver enzymes are not specific to a diagnosis, because basically what they're demonstrating is some sort of ongoing damage of the liver. So when you see an elevated ALT or AST, those are basically enzymes that are released by dying liver cells. So when there's damage to the liver, there's elevation in these liver enzymes. And so then we do these various tests to ascertain whether any of these conditions are contributing. And so for NASH specifically, there's no biomarker of NASH. However, say individuals who are diabetic, who have diabetes or overweight, and they have no other evidence of liver disease, like no other potential liver diseases based on these other biomarkers, then we ultimately conclude that they likely have NASH. So we will also do a test called a transient elastogram to assess whether there's significant fat accumulation and whether there's any scar of the liver in response to ongoing injury. Many people will have had an ultrasound demonstrating a different, what we call echo texture, or a different sort of appearance of the liver, suggestive of steatosis or fat accumulation. So normally, NASH is really a diagnosis of exclusion. Now, the gold standard for diagnosis is to do a liver biopsy. Many individuals will have a liver biopsy, but it's not actually necessary to establish that diagnosis, because we are able to do tests to rule out those other those other common causes of liver enzyme elevation.
Gotcha. Now, this is a question from the audience. So you touched a little bit about the serious outcomes that fatty liver can lead to, including cirrhosis. fibrosis.
Yes.
And this audience member asked, can you die from it?
Yes, it is possible to die of fatty liver disease. So as I'd mentioned earlier, say of 100 people who have fatty liver disease, 5 of those individuals will end up with cirrhosis of the liver, and then 2 to 3 out of that initial 100 can develop end-stage complications of fatty liver disease, so of NASH cirrhosis, as we call it, which include signs of fluid overload, confusion, so hepatic encephalopathy, which is due to ammonia accumulation in the system. And so basically, they will also develop liver dysfunction. So the liver is our metabolic factory and is critical to producing proteins that are essential for life. So what we see over time in a certain proportion of individuals who have fatty liver disease is end-stage cirrhosis. And this can result in death, unfortunately. Now, I think there's more and more awareness of this condition, and there are ongoing developments in this field and newer, say, medications that are being investigated. So there's much more awareness and, say, blood tests being done by physicians looking after individuals with diabetes, particularly, and obesity, because that population particularly is susceptible to this condition. And so there's much more of that awareness and wanting to ensure that the best care is able to be given to a given individual.
So you mentioned in terms of risks that there's genetic factors, diabetes, obesity can predispose one.
Mm-hmm.
What about children? Can kids get fatty liver at a young age?
Yes, they can. So this is really, again, I think in concert with lifestyle changes that have arisen over time in the last few decades, and with the growing incidence of diabetes and obesity in the pediatric population, certainly there is more and more evidence that, say, children can develop and do develop fatty liver disease. So it's not to the point of developing cirrhosis in those first 20 years of life, but then, you know, the fact that they have significant fat accumulation within their liver doesn't bode very well for their longer term, say, development of cirrhosis and complications thereof. You have to also think that fatty liver disease is really a multi-organ disease. So it's not just the liver that's affected, but certainly given that the liver is the metabolic factory of the body, certainly there's a multi-system effect, which is impact on cardiovascular, so the heart, the health of the heart, the health of other parts, body parts, including the kidneys as well. So there really has to be an awareness that really fatty liver disease is a multi-system disease in the end. So in fact, the number one reason for mortality or death in liver disease, fatty liver disease, is actually not liver failure itself, but rather related to more the cardiovascular aspect. So that really is something that people need to be aware of. So the liver health really has an important role on multi-system health.
Okay. I'm a big proponent of patients or family members kind of being aware and advocating for themselves.
Mm-hmm.
So if someone gets a diagnosis of fatty liver, are there certain things that if aren't done that they should, you know, ask their family doctor or urgent care to look into? So specific, I guess, tests again or investigations that you would recommend?
Mm-hmm. Yeah, so say in diabetic individuals, I think people who have diabetes or are overweight, particularly over the age of 40, I think it would be important to do liver enzyme tests to see if there is any associated NASH and whether there is an impact on their liver health. So we do know that 70% of individuals with diabetes have some degree of fat in their liver, and about 30 to 35% of people with diabetes will have NASH. So certainly in that population, I would highly recommend having their liver enzymes checked along the way. Now, in terms of other aspects of their health and lifestyle, I think particularly in individuals with diabetes, it's critical to manage their blood glucose optimally and ensure that they're able to engage in exercise in order to achieve some weight loss. A Mediterranean diet is actually very helpful. In fact, there was a recent study demonstrating that a Mediterranean diet was comparable to a hypocaloric diet in terms of being able to achieve weight loss and decrease in NASH. So I think overall, if there's a decent, say, balanced diet that is a bit hypocaloric in comparison to what might be ingested normally, then that could help in achieving weight loss, which is ultimately helpful in terms of remodeling the liver's metabolism.
Okay, so I'm jumping ahead a little bit. That was a question coming up, but in terms of, so you mentioned the Mediterranean diet.
Yes.
What about the diabetes diet? Are they similar in terms of recommendation, and is one better than the other? I suspect they're probably pretty similar in terms of.
So what I'm aware of is basically this Mediterranean versus hypocaloric diet comparison in a randomized control trial, and that was actually presented at the American Association for Liver Disease meeting in November of last year. So this was actually a randomized control trial that demonstrated that both diets were equivalent in terms of achieving both weight loss, improvement in the glycemic index, as well as significant improvement in NASH. With respect to the diabetic diet, I don't believe that any such trials have been conducted. As per my knowledge, I'm not aware of any such trials. From what I know, this was actually the first real randomized controlled trial to demonstrate an improvement in NASH. Regardless of the type of diet, really, it was ultimately the number of calories ingested that then resulted in improvements in both weight, glycemic index, as well as NASH.
Well, thank you, Dr. Bhat. So my next question is, are there any, you were mentioning earlier that there are some medications that are being investigated.
Yes.
Is there something available now that you can tell us about, or sort of future hopeful medications?
Yeah, so for NASH specifically, there have been several trials. Unfortunately, most of them have not resulted in the anticipated endpoint. So the endpoint, or the primary endpoint of these trials has really been to look for improvement in fibrosis or improvement in scarring. And in these trials, however, that have failed, they have noted to variable degrees some improvement in the NASH inflammatory activity, or the inflammation, but not the scarring. So one such very promising trial was published last year looking at a GLP-1 receptor agonist. So it's a type of diabetes medication called semaglutide. So that has significant promise. So it was published last year. There was a trial of this medication that demonstrated significant improvement in NASH activity, but not specifically scarring of the liver. So there was no significant improvement in scarring of the liver. So I believe in NASH really moving forward, it's going to be a combination of medications that target the metabolism and work on that aspect, plus the fibrosis, because the fibrosis or the scarring aspect is actually quite pronounced in certain individuals. And so I think it will be a combination of the two types of medications that in future we will see employed for NASH. in the meanwhile, really, most of our focus has been on, say, dietary changes as well as exercise. As much as is feasible. For many patients, it might not be feasible. It isn't feasible, unfortunately. So I'm very hopeful about the future of medical therapy for NASH, pharmacological therapy. And really, it has been moving in a positive direction in recent years. As you probably know, there are many trials. Most trials have unfortunately failed, but they are trying to target different mechanisms of NASH physiology or NASH pathogenesis, as we call it, or the biology of NASH. And I think ultimately it's going to be a combination of both metabolic and anti-fibrotic or anti-scarring agents that together will help patients with NASH.
Gotcha. And right now, in terms of, so if a patient were to adopt a very good diet, very good lifestyle, achieve a certain amount of weight loss, but they're already at the fibrosis stage, can they kind of go back from that? Can the liver heal from the fibrosis or cirrhosis?
Yeah, so actually what we know, especially from the hepatitis C literature and even from alcoholic liver disease, we know that, say, when an insult is removed, it is possible to have improvement in the liver function and the complications of liver disease. So even in individuals who have end-stage cirrhosis, they can have significant improvement over time in their liver function and scarring to the extent that they no longer need to be considered for a transplant, for example. So I work in the field of transplant, so I'm giving this as an example. So say we know in the hepatitis C world that patients with advanced fibrosis or advanced scarring, when they were treated for their hepatitis C, had subsequent improvement in their scar. And that's really because of the liver's miraculous ability to regenerate. So the interesting thing about the liver is that it's the one solid organ that has this capacity to regenerate. No other solid organ is capable of that. So it's really impressive. And we actually leverage that or harness that ability in living donor liver transplantation. Because there, in that scenario, what you have is resecting up to 70% of the healthy donor's liver and giving that, transplanting that into the recipient. And then both of those liver volumes regenerate miraculously to close to normal volume by 12 weeks after the surgery. And so this is why actually that, say, an insult to the liver takes a very long time to then result in cirrhosis, because the liver does have this ability to regenerate in response to an insult. As well, it also has this scarring response. So it's basically both of those responses occur in tandem. Now, once someone develops end-stage cirrhosis, that ability to regenerate is compromised to a significant extent. But particularly younger individuals with end-stage cirrhosis can have significant, what we call recompensation or resolution of those complications of liver disease. And that's because, again, because of the liver's ability to regenerate. So it is possible. So coming back to the main question regarding NASH cirrhosis, it is possible to have some degree of what we call recompensation if there is significant control of the NASH activity or the NASH inflammation. Now, in my experience, really, and this is because we don't have any good pharmacotherapeutic agents at this point to treat NASH, but hopefully the same thing will occur in future, as in hepatitis C, which is that, if we have a good treatment against NASH, then we can save people from needing a transplant or death. So I'm hopeful that the coming years will show us significant progress in this field, such that we can even help people who develop end-stage liver disease with NASH.
Well, thank you. For the next couple of questions, they have to do with what you mentioned before, the link between diabetes and fatty liver disease. Tell us a little bit more. Do they know the reason that the two are linked? Or how are they?
So so type 2 diabetes, in type 2 diabetes, what basically happens is there is what we call peripheral release of free fatty acids that come into the liver. And that's because of insulin action in the periphery that results in free fatty acids. And those fatty acids then come and deposit within the liver. And that results in fat accumulation. And so this is why, particularly in diabetes, you have this accumulation of fat, which ultimately can result in development of inflammation.
Mm-hmm. And is there a way, so for those that have both, is there a way to manage both of them at the same time and help?
Yeah, so the first step, as I'd mentioned earlier, is really diet and exercise if feasible. So these are, say, lifestyle measures that work for both conditions, so both diabetes and NASH. And they can work to a certain extent. Of course, particularly if there's genetic predisposition and if there's ongoing difficulty in managing the diabetes, which is the case for most individuals, then certainly over time in diabetes, if say medications such as GLP-1 receptor agonists or SGLT2 inhibitors are appropriate, then these might be helpful for both the diabetes as well as the NASH. And so it would be like hitting two birds with one stone, really. So being able to treat with these agents, I believe shows, these can be efficacious for both the diabetes as well as the NASH at the same time.
Great. And for my last questions, this is specific questions to certain individuals that asked. So if you are on insulin for type 1 diabetes, or another individual is on metformin for type 2 diabetes,
Yes.
Are those medications safe for the liver? And do they also help with fatty liver?
Yeah, so metformin, there traditionally have been concerns about using metformin, particularly when patients have very significant end-stage liver disease. Now, however, there has been literature demonstrating that individuals with a certain degree of decompensation could still tolerate metformin without any serious side effects. Now, the concern for side effects really dates to the 1970s when there were cases of lactic acidosis reported, so lactate accumulation in the blood in individuals who were taking metformin. And so this is why we've sort of not been using metformin in patients with end-stage liver disease because there is that potential risk of adverse effect. That being said, there is, as I mentioned, some evidence that even patients with what we call Child-Pugh cirrhosis may be able to tolerate metformin with no adverse effects. I'd say in general, individuals with end-stage liver disease will be on insulin just because it's safer to use in that context, and people just feel traditionally more comfortable using that for the management of diabetes, whether it's type 1 or type 2 in individuals with liver disease.
Great. Well, thank you so much, Dr. Bhat, for all of your answers. I hope that was helpful for our viewers. And next up, please stay tuned for Alcohol, Pandemic, and Mental Health with GI specialist Dr. Eric Yoshida and psychiatrist Dr. JJ Sidhu. Thank you for listening.
Okay. Thank you so much, Valeria. It was a real pleasure to be on today.
I'm very excited to introduce our next guests of today's session, Dr. Eric Yoshida and Dr. JJ Sidhu. Dr. Yoshida is a highly respected liver specialist who has many accomplishments over his 30 years of practice. He is a full professor at the University of British Columbia and is well known nationally and internationally in the area of liver disease and liver transplantation. He is also the chair of Canadian Liver Foundation's Medical Advisory Committee. Dr. Sidhu is a graduate of University of British Columbia and Harvard University. He is the Department Head of Psychiatry for Vancouver Acute and Community, Medical Director of Mental Health and Substance Use for Vancouver Acute, Tertiary and Urgent Services, Medical Director for the BC Occupational Stress Injury Clinic. Dr. Yoshida and Dr. Sidhu will be speaking on a very important and timely topic, alcohol, pandemic, and mental health. Please join me in welcoming Dr. Eric Yoshida, Dr. JJ Sidhu, and our host, Dr. Valeria Zaborska.
So for our next session, titled Alcohol, Pandemic, and Mental Health, with Dr. Eric Yoshida, a GI specialist, and Dr. JJ Sidhu, a psychiatrist. A study done by NANOS for the Canadian Centre on Substance Use and Addiction indicates that 25% of Canadians aged 34 to 54 were drinking more while at home during the COVID pandemic. Another study from Sunnybrook Hospital in Toronto found that alcohol purchase increased by more than $250 million during the first 4 months of COVID in comparison to the same time in 2019. Similar reports are being found in BC, where alcohol use has been the highest in 2 decades during the first year of the pandemic. And in Calgary, and a study done at U of C found that the number of Albertans hospitalized for alcohol-related liver disease during the first wave of the pandemic has increased significantly. So that being said, there is definitely a big link between liver disease and alcohol. So I appreciate in advance you answering our questions with respect to that. So Dr. Yoshida, what is considered heavy alcohol consumption? What are the long-term health risks associated with heavy consumption?
Thank you, Val. Heavy alcohol consumption, let me rephrase that. According to the Canadian Centre for Substance Abuse and the National Institute for Alcohol Abuse and Alcoholism in the United States, they define a safe limit of drinking to be for women 7 to 10 per week, and for men no more than 14. Now, that might sound reassuring to some. However, a large study in the Lancet actually concluded that there really was no safe amount of drinking. They stated that the only safe amount of drinking was 0 drinks per day. And so I think that the actual amount of safe drinking is probably much less than what is recommended. I have seen some recommendations that from other countries that the safe amount of drinking is perhaps 3 drinks per week, which I think Canadians, Americans, and the alcohol industry would probably take exception to. But at the end of the day, there is probably no safe amount of drinking. On the other hand, I'm not saying that nobody should drink. In terms of the health consequences, let's put it this way. Alcohol costs the Canadian healthcare system about $16.6 billion in expenditures per year. In 2014, the Canadian Centre for Substance Abuse reported that 14,800 Canadians died directly or indirectly as a result of alcohol. So the health consequences of alcohol include obviously liver disease, but an increased risk of cancer, increased risk of death from trauma, whether it's accidental death or car accidents, suicides, it goes on and on.
Mm-hmm. Okay. And so you mentioned that it causes bad effects on the liver, when or after how many years, for example, of consumption, whether heavy or not, would you start seeing effects on the liver?
Well, alcoholic liver disease is actually a spectrum. So for fatty infiltration of the liver, like fat accumulates in your liver from alcohol, and keep in mind that even if you don't drink alcohol, 20 to 30% of the Canadian public and the American public has fatty liver disease, so that's a growing crisis. But alcohol deposits fat in your liver pretty good and within a short time. So a few weeks of heavy drinking and you can see some increased fat in your liver. Alcoholic hepatitis, which is a severe inflammation caused by alcohol, can happen within a relatively short time, months to a few years. Alcoholic cirrhosis can usually take years to even a few decades. Liver cancer from alcohol actually will take, the risk is about 1.7% per year in people with heavy alcoholic liver disease. That can actually take years to decades as well. So there's quite a spectrum.
Thank you. And now for Dr. Sidhu. So we talked a little bit about, higher risk of cancer, liver disease. What are some mental and emotional side effects of alcohol? And how does the alcohol consumption affect the brain, for example?
Yeah, that's a great question, Val. I think it's good to acknowledge that when people do reach for a drink or have a glass of wine at the end of a day or whatnot, they're really looking for some positive benefit, including, they might feel a little bit more relaxed, might make people feel a little bit more social. But in life, like many things, there's a double-edged sword to these things. And some of those things that we look to improve with alcohol in the moment, there's a paradoxical effect. For example, you hear folks that have a drink at the end of the night to help them sleep. But we know that our sleep is actually disrupted short-term and long-term by alcohol. Anxiety, mood, all those are two major areas of mental health that are impacted by alcohol use. And the impacts can be quite significant. Dr. Yoshida already mentioned suicide. So I see lots of patients in the emergency room setting for mental health crises and presenting with suicidal thoughts or even violence. And alcohol it's not uncommon to have alcohol involved in that somewhere. So we know that that alcohol is an implication in those events. Further, in long-term alcohol use can impact cognition, and in rare cases, something we call a psychosis, where your reality gets distorted. So there's certainly profound mental health consequences from alcohol use.
Great, thank you. And back to Dr. Yoshida. So we talked a little bit about the types of liver disease, so fatty infiltration and alcoholic liver disease. And you mentioned that there's a spectrum. How are these conditions diagnosed and what are the treatment options?
Well, again, that's an excellent question, Val. In the early stages, often the diagnosis is just from laboratory tests like blood tests that diagnose abnormalities of your liver. By the time you actually have symptoms like you're turning jaundice, like your eyes are yellow, and you're having other symptoms like you're having confusion because all the toxins that are cleared by the liver are just not getting cleared and zipping right to your brain and causing the brain to not to function well, and symptoms like that. By the time that happens, you're functioning on less than 10% of the reserve of your liver. So your liver is very compromised. Now, even the worst cases of liver disease that I've seen can somehow and miraculously improve with time after stopping alcohol. That's one of the things I've picked up after 30 years of being a physician at the Vancouver General Hospital. But a lot of times it doesn't improve, or there's some improvement, but it plateaus pretty quick, and the patient's still in trouble with a high mortality for the short and medium term. You got to think about a liver transplant. The problem with the liver transplant is there are so many people who need a liver transplant from all causes, not just alcohol, but all the other causes. And there aren't that many donors. So it's kind of like the Titanic. There's a lot of people whose lives need to be saved, but there aren't enough spaces on the lifeboat.
Gotcha. I do have a couple of follow-up questions about liver transplants, and I'll get to them in a little bit. So you mentioned that some of the symptoms it can cause, you have toxic effects on the brain. What are some symptoms of liver damage from alcohol, or things that a patient or someone in our audience can look for that should ring alarm bells that they should go see their doctor and have it looked at?
Well, I think aside from jaundice, which even your family members or the postman can say, hey, you're jaundice, buddy. You got to think about other things. The accumulation of fluid in the abdomen, which is ascites, sometimes you can accumulate enough fluid that you look like you're pregnant. You're like almost at term. I mean, that's not uncommon, and that's when the liver is really advanced. Massive internal bleeding can happen with advanced liver disease from any cause, including alcohol. Muscle wasting. To be honest with you, end-stage liver disease of any cause tends to be what we call a very catabolic kind of process, which means that your body can't use the calories efficiently, and your muscles start to atrophy and waste away. Now, one of the things about alcoholic liver disease is that alcoholics tend to be malnourished to begin with because they're getting all their calories from alcohol. So you got a double whammy with those people. They have they're malnourished to begin with because they're just not eating enough decent food, and then they have this end-stage liver disease, which is causing them to waste away.
Mm-hmm. Thank you. And back to Dr. Sidhu. So we're talking a little bit, I brought up about the fact that the studies show that alcohol consumption has really increased. So how does one know that their consumption is becoming problematic and that it's going from what was previously considered safe to a zone where you should start thinking about it and maybe seeking help? And what are some early warning signs that anyone can watch for to make sure they don't progress?
Thanks, Val. Yeah, that transition point can be fairly incremental, and it can creep up on you. So there are certain things that I say to folks. One, if you're ever in a situation where you feel you're medicating yourself to deal with things like I'd mentioned, like for sleep or for anxiety, or just to kind of unwind, if that becomes like a regular pattern, that might be something to pay attention to. Further, people in your circle might start to make comments, and if you find that you're getting annoyed or irritated with some of those comments, I mean, it's really easy to feel defensive, but maybe it's something that just to pay attention to. Anytime that substance use or alcohol use starts to impact our day-to-day life, right, our functioning, at work or in relationships or recreational or social realms, and certainly our health. Those are things to pay attention to. Dr. Yoshida has mentioned some signs and symptoms to pay tabs on. Alcohol is something that people build tolerance to. So initially, someone might start with having a glass of wine, but over time that might turn into 2 glasses of wine or half a bottle, and then those other negative effects start to accrue. So those are in a kind of a bird's eye view sort of picture of some things to pay attention to. There are questionnaires that your family physician might ask you, or your health provider, that can screen for this. But there's certainly some self-reflection, I think, that's involved, and paying attention to the people that care for you, right? People are generally in your circle, they're looking out for you.
Great, thank you. And the next question is a little bit broad and complicated, so I'll try to ask it in simplest way possible. But you were mentioning that sometimes people can use alcohol, for example, for sleep or anxiety, for mood. Is there a relationship, or one that causes the other or the reverse, between mental health, including like depression, anxiety, and alcohol use? So is it that alcohol can lead to those, or is it that anxiety, depression can lead to alcohol use?
Yeah, it's that old chicken and the egg question, and it's a fairly complicated question in a lot of ways. But the short answer is probably both. So certainly, certainly one can just develop an addiction to alcohol or develop alcohol use disorder without any history of trauma or mental illness. There are things in place in society, I think, that condone it. For example, social norms, going out with friends, going out with folks. It's condoned in many settings, or has been historically. But we also know that individuals who have had adverse life events early on, or traumatic experiences, depression, anxiety, are at increased risk for addiction, as well as including alcohol use disorder. So there's quite I think, a complex interplay, and sometimes it's really hard to unwind. But we do want to pay attention to both domains.
Gotcha. And then similar, so with liver disease, Dr. Yoshida was saying that if you stay abstinent or you don't drink less, that sometimes you can improve. Can the same be done with the cognitive effects of alcohol on the brain? So if you've been using alcohol for a long time and developed some cognitive changes, if you stop, can you reverse it?
Yeah, excellent. Thanks for bringing that up. So I had mentioned earlier that one of the adverse effects of long-term alcohol use is that cognitive decline that some people do experience. So there is positive news, I think, in some cases, certainly, like over time, that if you remain abstinent, some of those, you do see improvement. And I've seen that. I've seen with patients that have had heavy alcohol use disorder, and they've managed to abstain, and we've seen over the course of months or a year that there's been significant improvements. So I know for many individuals in our communities, they are paying attention to that. They are worried about their memory. Yeah, that is one concrete intervention that one can do, is try to abstain from alcohol and just see and track those improvements over time. The same goes for those other aspects of mental health. Just going back, there are certainly cases where the cognitive effects do not prove, where people are using heavy amounts of alcohol over the course of years, and unfortunately, we do see that as well. But going to mood and anxiety, so if someone's able to abstain from alcohol, we can see improvements in those areas as well. So when people are using alcohol over a short, medium, and long term, changes occur in the brain. Certainly there's some cellular changes. Alcohol is cytotoxic to the brain, meaning that a cell death occurs. But also the brain sends messages through neurotransmitters. There's a whole bunch of neurotransmitters that we have in the brain, and those are impacted by alcohol. And it's sort of like changing the climate of a system, or of the brain. So people are developing anxiety or a depression as a result of alcohol. It may take some time for those things to improve after stopping alcohol use, but we do see improvements. So there's some hope in that area as well.
Great, thank you. And going back to Dr. Yoshida, so we were talking earlier about transplants. Can you tell us a little bit about the process and the potential possibilities of someone who did have heavy alcohol use or alcohol-related liver disease? What would be the steps that need to be taken for them to be considered and potentially get a transplant?
Well, first, they have to be referred for a liver transplant. And so the first step comes with seeing your physician, and then in an outpatient setting, getting referred to an appropriate specialist, an internal medicine specialist or a gastroenterologist, and then having them refer you to the outpatient pre-transplant assessment clinic. And there is quite a workup. This is quite a complicated and technically demanding surgery, and it is very demanding physiologically on the patients. And so there needs to be thorough cardiac investigations, heart investigations, make sure that the heart is functioning well, make sure the coronary arteries aren't too clogged up. There has to be an assessment of any comorbid illnesses. Any cancer that's not cured is definitely not a good thing to go into for a transplant, because the anti-rejection drugs and cancer is kind of like throwing gasoline onto a fire. And then there is the allied health situation. The patients have to see a psychologist who has, and we have transplant psychologists whose their specialty is transplantation, transplant social workers. You need good social support, and you need basically a commitment to abstinence. With if you need, after a transplant or even the waiting time, you need to see counselors. Well, you should do that. I mean, that's absolutely necessary, because the last thing anybody wants, including a transplant recipient's family, is to have somebody undergo a liver transplant for alcohol and then resume drinking such that afterwards, such that they endanger the newly transplanted liver.
Gotcha. Thank you. Definitely sounds like a complicated process, but also sounds like there is hope, especially with counseling and support, social support. Now back to Dr. Sidhu. Why do some people develop an addiction while others don't? We can talk about alcohol specifically. And does the risk differ between men and women?
Another good question, Val. And another complicated one, I think. It's, we hear about genetics and addiction, and certainly that's a component. And if you have alcoholism in your family, it's something to pay attention to when you're choosing to indulge in alcohol use, because your risk likely is higher. However, that's not the whole picture. There are other elements to it. Certainly, some of those things that we've already discussed, such as if you have an underlying mental health illness, especially something like anxiety, PTSD or post-traumatic stress disorder, depression, you could be at increased risk. If you started early in life, we know that's associated with a greater risk of alcohol use. And when it comes to biology and gender differences, there is some evidence out there that does highlight some differences. Historically, I think men have consumed more alcohol. However, there's a pattern where we're seeing where women actually have perhaps more adverse harm that's coming from alcohol use. And, that could be related to actual biology, again, could be influenced also through societal norms, situations where some patterns have emerged where women might be using more to cope with certain adverse negative experiences than men. So it's an interesting field of study, and I think over time it's changing. Patterns of prevalence of alcoholism is different in different communities. For example, one country to another or one province to another, we might see differing rates.
Great, thank you. And this is a specific question from someone in the audience. So this individual struggles with both mental illness and heavy alcohol use. And they were told by a counselor that they should remain abstinent for 90 days before getting help for their mental illness. And they were just wondering if, in your opinion, this would be a reasonable approach, or if you would recommend approaching both at the same time, or if you can kind of recommend sort of how to approach the situation for this person.
Yeah, there's a term called concurrent disorders, and that speaks to individuals who suffer from both an addiction as well as an underlying mental health illness. And it's not a small group. And in fact, I think we're recognizing it's more likely to be the rule as opposed to the exception. And recent evidence is supporting that as well. So that idea that where you would treat the addiction first before you touch the mental health illness or vice versa, it's a little bit of an older school of thought. That being said, certainly there are times where we do focus on one. So if the alcohol use disorder is so severe that we can't reliably access with the underlying depression or whatever is going on underneath that, we might focus in a sequential way, kind of deal with the alcohol use disorder. You know, if somebody's using quite a bit, we might get them into detox, because withdrawing from alcohol can be quite dangerous and potentially life-threatening. If you're, you know, people can have seizures, or it can affect their heart rate and blood pressure. So it's something that we are encouraging many of our services to look at from that dual perspective. So, you know, you have somebody in front of you who's struggling with alcohol or any other substance. It'd be almost bizarre to think that doesn't affect your emotions, your thoughts, your relationships. So we're complicated beings, humans, right? Multiple layers to that. So we want to be able to approach it from that concurrent or dual approach.
Thank you. And for our last question, I think this is for both of you. So if someone is noticing that their family member has been struggling with excess alcohol use and they're worried about their liver health, their cognition, what are the best resources that you recommend to your patients? Where can they access them? And is there anything that's, you know, more affordable for those that can't pay for private counseling? Sort of, what are the avenues that you direct people towards?
Well, I think that the family doctor has to be the key person to touch, for that individual to touch bases with. The family doctors, they have a wealth of knowledge. They also have a network of people who they refer to, people who they can work with. And most family doctors, this wouldn't be a new problem for them. They've had lots of other patients who have had similar problems, so they know what path needs to be traveled.
Yeah, and I was going to say the same. That's a really great resource to the family physician, because it's not a short-term thing, and you want to be able to develop a relationship with that. And alcoholism does not affect an individual necessarily. It certainly does, but it affects the entire system. That's their family, their friends, their relationships, their work. Many communities have a central line or a phone number or a service for addictions issues, and that's a really good number or service to find out what's the one that's specifically in your community. From there, they will offer a whole host of services, and there's quite a spectrum, everything from individual therapy to group therapy, where you might have a trained health professional providing behavioral treatments. Your GP can offer medication. There are medications that actually help with alcohol cravings and alcohol use disorder. And in conjunction with those treatments, those behavioral and psychosocial supports, some good things can happen in terms of the treatment of alcohol use disorder. And then we hear about peer support groups, such as, you know, an example, a common one is alcohol AA, right? Alcoholics Anonymous. And there's other ones as well, like Smart Recovery, which is more less spiritually based. And then at the other end, there are more expensive interventions, potentially, like an inpatient setting where people would go to stay. There are also publicly funded settings as well. So quite a spectrum of services are available.
Great, thank you. Well, thank you both so much for sharing your valuable knowledge on such an important and timely topic. Now, for everyone else, please stay tuned for Dr. Charles Scudamore's liver health tip of the day. Thank you so much.
Thank you.
Thank you.
Hello, I'm Dr. Charles Scudamore. I'm a liver surgeon, and we're going to talk about alcohol. First of all, we've been drinking alcohol for as long as humans have recorded history. And just now, we're actually finding things about alcohol which are of some concern. In some people, no amount of alcohol is good. In others, our society demands us to drink some alcohol. In order to avoid liver disease with alcohol, there's a few short things you should remember. One is, don't drink excessively at one time. 2 units of alcohol, i.e., 2.5 ounces of hard liquor would be as much as one should drink in one day. If you can have 2 consecutive days without any alcohol at all, that would likely prevent damaging your liver long term.